along those lines, you mentioned the word communication. I am teasing out of that. Can we talk about that a little bit? No pun intended here, but communication is critical for the success of these immune therapies. Reason being is I like to describe these immune therapies as like letting the genie out of the bottle. You just don't know what's going to happen. You have to be prepared. Again, the reality is there may not really be any side effects or minimal side effects, which can happen. But what are the kinds of things that we need to educate our patients about from a logistical or practical point of view in terms of when receiving immunotherapies? Let me give you an example. One of the challenges I've run into in the past is if I have an individual who lives alone, perhaps lives alone and doesn't have a lot of resources or friends or family members that may be able to accompany them to an appointment, or I'm concerned that an individual may not be as forthcoming with the development of symptoms or side effects. In other words, they won't call me if they don't feel well. They don't want to be bothering us, or they just don't feel like it's that big of a deal. This happens more regularly than not, unfortunately. So have you found any pearls about how you can help patients really understand the concept that we absolutely need them calling us early, because we know that early intervention is the key to success? We want to be identifying and managing a problem when it's this big rather than it's this big, because in the long run, they'll do better. So I'm hoping you can share some insight about what you or your practice or colleagues, or if you've learned anything about how we can really empower patients to advocate for themselves, because in the long run, that's what's going to help keep them on therapy. So enlighten me, Kathy.
So you bring up a great point about patients who live by themselves, but there's sort of a spectrum of folks, and some people are extremely private and they really don't want people to know what they're going through. And that doesn't mean that they're not responsible for their process. Some folks can be very responsible. And then other people that can be a little bit of denial, they can kind of, they're not, they're embracing their journey at it's just a different pace. And we really have to meet patients where they're at, and we're guides for them. And one of the things that I do like to share as an analogy is that patients are the captains of their own ship, and that the rest of us, we're navigators. We can serve as first mates. We help, but really the team is your crew of navigators. And sometimes we have to take the wheel only for a short period of time, but by and large, the patients are the one who guide their own journey, and they get to be at the helm of the decision making of where this journey is going. And so a lot of people kind of relate to that, and that they understand, like, you're in charge here, but you are not alone, because you can't go along this journey completely by yourself, unassisted, unsupported. And so we really try to emphasize having people there as supports. Not only it can be helpful on a psychological level, but it can really be very helpful on a physical level, and in ensuring people's safety. And I really always impose that that concept that we're here for your safety. Now that we've made this decision, everything moving forward is about making sure that we're keeping you safe while we're reassessing that this treatment is effective. So if I identify that somebody may be it doesn't have a lot of resources, maybe sort of just is kind of someone who really appreciates their privacy, lives alone, doesn't really have a lot of connections, we really sit down and talk about the importance of having to identify at least one or two other people, maybe somebody in the area. So if if they're not feeling well, there's someone to check on them at their home, their apartment, their townhouse, their boat, wherever that they might be residing. And then also making sure that there are ways to connect with that individual. Do you have a
And
cell phone?
you're doing this right up front. You're kind of bringing this up initially so that you're kind of setting the stage for, okay, if this happens, here's what we're going to do. So essentially you're developing a contingency plan for health. Is that fair to say?
It absolutely. And some of that can also fold into it, talking about folks who might be able to serve as a healthcare proxy, and bringing
And meaning what? Define what you mean by healthcare proxy in this setting.
so in this setting, this is someone who, if in the event the patient weren't able to advocate for themselves, that this could be someone who could step in and help make healthcare decisions for that individual. And that's not usually what's happening in our office setting. But that could be in case there's something unforeseen or unexpected that occurs. And
I'm going to jump in here right now
Yeah.
because this is making me think about a patient that I had who was in a similar situation or a situation, and that they couldn't make decisions for themselves because they had a side effect from the immune therapy that was causing a part of the brain to become inflamed. So they were really so tired, so fatigued, that they really couldn't have a conversation. And it wasn't for end of life in any shape, way, or form reasons. This was a side effect from the immunotherapy. And you're making me think about this individual now, because I remember he was a gentleman in his middle age life and had to have his mom involved with his care, which was unsettling for him as a grown man, but he was unwell and his mother had to step in and say, look, this is not so-and-so's normal behavior. Something is wrong. Something is up. And out of desperation, she stepped in because she was so worried about him. But I'm thinking about this because that's an example. That's a good reason for having to have a healthcare proxy step in these cases. What I regularly remind my patients is sometimes the immune side effects occur because the drug is working. The medication is working and it's causing almost too good of an effect on the body. The immune toxicities that we see related to these agents are happening because something's working in the immune system. And sometimes it does too good of a job, essentially. So it was a particular a part of the brain that was affected, and this gentleman just was not able to make decisions. So I'm actually thinking about that now. That really was a role as a healthcare proxy for that family member to step in and advocate for that patient, and for good reasons.
so that's a great example. That's an exceedingly rare example, right? And I've had that happen as well to a very young patient having adjuvant therapy. And it's scary for the patient. It's scary for the provider team. It's scary for the family or care support team for the patient. But it's a very good example of saying sometimes there are just some unforeseens, and then having these conversations, not because somebody's dying, but because there are potentials where their normal could become abnormal, and it could impact their ability to maybe make decisions or take care of themselves for a period of time. And then we work really hard as the team to correct these types of toxicities and side effects. And fortunately, on my team's track record, we've treated thousands of patients with immunotherapies, and we've been able to reverse most of them, especially the ones that you just described. Krista, that was a pretty great example of a patient who had a really serious side effect. And as I mentioned a little bit before, a lot of the side effects tend to be more like those earlier mild to moderate. What type of examples do you have for some patients? And keeping in the spirit of patients who kind of want to be solving a problem. Maybe they've had an issue before of something with their body, and they're not really thinking side effects. Maybe it's something that wasn't on the sheet. Do you have any patients that?
Actually, I do, because this was a an example that I use when I'm educating other patients as well, because I think it's something simple we can all relate to. So I had a young woman, a woman in her 30s, who was receiving immune therapy, and she was actually doing quite well, feeling great. And she came in one day for a routine appointment due for her next treatment. And I noticed that she was having trouble walking, which I thought was very strange. And so in the midst of this, I said, so what's going on? You look like you're uncomfortable. And she's like, oh yeah, I'm having trouble walking, but it's not a big deal. I'll figure it out. And I said, no, tell me what's going on. And she said, oh, it's just my feet, the bottoms of my feet hurt, but it has nothing to do with cancer or my cancer treatment. So I'm going to work it out with my primary care provider. And I said, wait, time out. In my world, everything is immunotherapy related until proven otherwise. So tell me what's going on. And she said for the past week, she had been really having some lots of discomfort in the bottom of her feet. But long story longer, we ended up sending her to a podiatrist and did some additional testing. And lo and behold, she had plantar fasciitis. Now, plantar fasciitis is inflammation of, one of the tendons in the bottom of the foot. Why would she think that has anything to do with immune therapy? Well, the reality is that it is, because any part of the body that has an immune cell, which is everywhere, can be inflamed. And in this case, it was the tendons in the bottom of her feet. It was very manageable. The podiatrist helped with some orthotics, and we got her some physical therapy, and she was able to function. But it was a great pointer because from her perspective, this had nothing to do with cancer or cancer treatment. So why even think about bringing it up to me? And number two, it wasn't severe enough. It wasn't life-threatening. It wasn't anything that was going to put her in the hospital. So she didn't want to be wasting anybody's time. But the reality is it was inflammatory based. And number two, it was early enough that we could make a difference. So the fact that we can intervene as early as possible in the long run has the best outcomes. And I'm sure you have lots of examples of this as well. It's sometimes hard to make the connection that a side effect is happening or not. So what I tell patients is anything that seems out of the ordinary, anything new or different from your particular baseline, we want to know about it. Even if it's just to mention it, we may say, it's okay, we're going to follow it, but it could also be a red flag to us. So it's always best to disclose. You're never bothering us. You're never complaining. I like to use the word reporting, because you are reporting what's happening in your body. It's not a complaint. We are learning how these medications affect everybody and anyone. So I learn from everybody. So please keep reporting and reporting, but you must have an example of something along these lines too, Kathy.
Absolutely. And, we're dealing with mostly very capable adults, people who were used to solving these problems, taking responsibility for issues, taking the initiative to follow up. And I had a patient who came in just recently, and I did my usual starting at the head and going all the way down. And we really try to be very detailed and go through each system and go all the way down to the feet. And I made an observation, because it was very visible to me, that his eyes were a little bit red. They looked a little bloodshot, both of them. And so we touched on that, and I said, all right, well, let's circle back to that, because I think we need to spend a little bit more time, because I figured since he felt great otherwise, everything else was going to be okay, and it was. And then we circled back, and I said, okay, so tell me a little bit more about this vision. And it's, I can see, but things are a little bit blurry, and I'm a little light sensitive, and but this is just like it was when I got my cataracts, and I had them as a young man, and I made an appointment with my ophthalmologist, but it's been going on for like a week and a half. It's a little bothersome, but it's like not a big deal. So I'm going to see my ophthalmologist. And I was like, I'm out. Okay, and of course we want to emphasize kindness here, and saying, all right, well, you agreed when we started this that you would give us a call if anything changed. Yeah, but it's like my cataracts. And I was like, yeah, but you had those fixed. So I utilize this opportunity with this eye inflammation which we emergently did get him to an ophthalmologist, same day, like within a couple of hours. And he did have this anterior uveitis, which is inflammation of the uveal layer in the eye. And it can be kind of serious and affect visual acuity. And if the inflammation goes on too long, it could potentially create some more serious issues. So fortunately, got some anti-inflammatory eye drops. We held the treatment. But had I known about this a week and a half earlier, maybe we could have mitigated how intense it was, and that we could have intervened a little bit earlier, and maybe we could have stayed on track with treatment. It's okay. Staying on schedule with treatment is important, but it's not the end all be all. The schedule is there as a guide. And we know with immunotherapy, once we release the horses out of the barn, as an analogy of once we release the immunotherapy into the system, we don't really know how anyone's individual personalized immune system is going to respond, and how quickly, how briskly, what it's going to aggravate, what it may not. And we're particularly sensitive to people who have autoimmune disorders. So it's really important to make sure that we do incorporate that review and history. But getting back to my patient who had the uveitis, he didn't realize it. And I didn't expect him to realize that. But what I utilized that opportunity with was, when anything is different, having started the immunotherapy, anything from that time point on that changes, even if it's a change that might have happened to you in the past, something familiar to you, the difference is now you're on immunotherapy. Now you're receiving it. So it could look like something you've dealt with before. And that doesn't mean that we're not going to maybe utilize one of your providers as part of your team as for follow-up, but please call us first, because as Krista said, as you said, everything is our immunotherapy. I'm going to start there, because you could just have an average everyday problem. Maybe you did have some sort of, allergic eye issue thing, and it's not related to the immunotherapy, but we always default to it's the immunotherapy first until proven otherwise.
Yeah, I love that. That's also a good example too, because you're bringing up something that this patient has personal experience with in the past. So he was advocating for himself by making these appointments. But what we'd love to see is that we do it in conjunction with your oncology team. I like to say to patients, you're the expert on you, and we're the expert on the medication. So together we have to partner to figure out what the best care is for you. And that's going to differ than your neighbor who's also receiving immunotherapy or something along those lines. But we see things differently. We look at things differently as oncology providers when somebody is receiving immunotherapy. So we have to put that into the context of that individual's care.